Well, hello and welcome back to class. This is Applied Anatomy and Physiology, AAP 301 for the College of Natural Health Sciences, Bermuda. My name is Dr. Delcina Bean Burrows, and this is lecture number 11. We will be looking at the lymphatic system. So in our lecture, we are going to consider the learning objectives, the key terms, what is lymph, lymph vessel network, lymph nodes, lymph formation and movement, and the types of edema. Before we get started, why do you think physical movement can help keep your fluids flowing? If your ankles are swollen from standing all day, how could walking home help reduce that swelling rather than make it worse? So the learning objectives for today's lecture are that upon completion of this chapter, you will be able to discuss the importance of understanding fluid return and immune response as separate roles of the lymphatic system and how this relates to manual therapy practice. Name the primary components of lymph. Identify the three categories of lymph vessels and describe their key structural features. Explain the general structure and functions of a lymph node. Explain the process of interstitial fluid uptake and distinguish this process from lymph flow. Describe the key internal and external mechanisms that create and influence lymph flow. Name and locate the primary lymphatic catchments and watersheds of the body. Explain the different routes of lymph flow back into cardiovascular circulation for the torso and upper and lower extremities. And compare and contrast the three major categories of edema. And the key terms that we will look at today are anastomosis, anchor filaments, angion, angulus venusus, catchment, dynamic edema, edema uptake, lymphatic terminus, lymphedema, lymphodome, obligatory load, pre-lymphatic channel, traumatic edema, and watershed. We begin our lecture today by describing the lymphatic system. The lymphatic system is a vascular network that returns interstitial fluids, large protein molecules, and cellular debris back to cardiovascular circulation. We know that manual therapy may impact fluid flow and edema. Lymph is the fluid contained within the lymphatic system. It is extracellular fluid, and it has an obligatory load that absorbs into lymph vessels, the components of which are water, proteins, cells including lymphocytes, foreign substances, and the long-chain fatty acids. So it's time now for our first What Do You Think segment. And remember, the What Do You Think segments are designed to start to make you to think clinically and critically, and it is a part of the clinical reasoning process. The first question is, how would you summarize the cardiovascular and lymphatic systems' interdependent roles in circulating fluids throughout the body? And why do you think it is important to know that lymph obligatory load is more than just water? Let's talk about the lymph vessel network. The lymph vessel network consists of the lymph capillaries and the pre-collectors, the collector vessels, and the lymphatic trunks and ducts. Let's take a closer look at the lymph capillaries. Lymph capillaries, or initial vessels, are the smallest and first vessels in the lymphatic network. They entwine with the cardiovascular capillary bed and are described as blind-ended because they begin as snub-nosed tubes in the interstitial spaces of the subepidermis. Like cardiovascular capillaries, the walls of initial lymphatic vessels are formed by a single layer of epithelial cells, but the lumen of an initial vessel is 4 to 6 times larger than that of a cardiovascular capillary. The basement membrane, also called the basal membrane, which forms the external covering of the initial capillary, has a much looser weave, making it only a partial membrane. In several areas, there is no outer membrane at all. This makes initial vessels much more permeable than cardiovascular capillaries and functionally more absorbent. The epithelial cells of the initial vessel overlap each other by approximately 1/3, like fish scales. They have microscopic fibers called anchor filaments that hold the initial vessel in the interstitial space and open the vessel by pulling the overlapping flaps of the epithelial cells outward. Taking a look at the precollectors, several microscopic lymph capillaries converge into a slightly larger vessel called a precollector. These vessels are located in the deeper zone of the dermal layer of skin. While precollectors absorb some interstitial fluid, they are less absorbent than initial vessels due to structural distinctions. Their walls have several layers of epithelial cells with no anchor filaments, and the basal membrane around the outside is complete with only a few gaps that allow fluid to enter. Generally, there is a single one-way valve at the junction between the initial capillary and precollectors, although it is not as strong or rigid as the valves found in veins or the collector vessels. As precollectors get closer to primary lymph vessels, called collectors, they thicken as the number of epithelial layers increases and the connective tissue sheath around the outside becomes complete. In several regions of the body, multiple precollector capillaries are arranged end to end, similar to the arrangement of a capillary bed in the cardiovascular system. This end-to-end arrangement forms a structural feature called an anastomosis. The precollectors in anastomoses essentially do not have valves, meaning lymph can flow in either direction. The importance of this feature is discussed in a later lecture. And here we have illustrations of the lymph vessel network. To the left, we see the initial vessels converge into a precollector. Several initial vessels converge into a single precollector, passing through a weak one-way valve. To the left, the anastomosis connecting two connecting vessels is illustrated. If a collector is blocked, the anastomosis provides a crossover route for the lymph to flow into a different collecting vessel. Let's now consider the manual therapy applications with respect to the lymph vessel network. All manual lymphatic techniques include superficial strokes that gently stretch and then release the skin. This light stretch of the epidermis opens the initial vessel by pulling on the anchor filaments attached to the overlapping epithelial cells of the vessel wall. The opening created by lifting the epithelial flaps is large enough to allow the passage of proteins, cellular debris, and other substances that are too large to be reabsorbed into the blood capillaries. When the tissue stretch is released, the cell flaps of the initial vessel snap back into place. Like slamming a door, this sudden closing of the cell flaps helps propel lymph from the initial vessels into the precollectors. Let's now discuss the collector vessels. Several pre-collectors converge into larger lymphatic collecting vessels, also called collectors, which are the primary vessels for lymph transportation. These vessels contain a series of one-way intralymphatic valves along their length, making them structurally similar to veins. The valves located roughly over 0.25 to 0.79 inches and divide each vessel into a series of smaller segments, so lymph also has to move from one short segment to the next instead of traveling the full length of the vessel at one time. Each segment forms its own functional unit called an angion. The collectors have a smooth muscle layer in the vessel wall that spirals around each individual angion, similar to a stripe on a barber pole. Like all smooth muscle, the spiral muscle in the angion is under autonomic control, which stimulates regular rhythmic contractions. These contractions create an internal pump for lymph movement through the vessels. We have both superficial and deep collectors. Superficial collectors are located between the dermis and superficial fascia, collecting lymph from skin and subcutaneous layers. Deep collectors extend from the subdermal layer of skin into the fascial layers of muscles, joints, and viscera. An important feature of the deep collectors is their alignment with the major arteries and veins in those areas. In fact, they share the same fascial sheath. Now let's take a look at the lymphatic trunks. The group of collectors that carry lymph from the extremities, head, and viscera into the thorax are called the lymphatic trunks. These lymphatic trunks lie deep within the body tissues and, like deep collectors, are generally situated alongside major arteries. The lymphatic trunks empty lymph into one of the two largest vessels in the lymphatic network, the right lymphatic duct or the thoracic duct. Like the lymphatic trunks, these ducts lie parallel to major arteries and are situated deep within the tissue or ventral cavities. In our illustration here, we see the major lymphatic trunks, deep ducts, and the terminus. The lymphatic trunks carry lymph from the afferent collectors to the two deep ducts of the lymphatic system. The lymphatic terminus is the point at which fluid from the lymphatic vessel network is returned to the cardiovascular system at the subclavian veins, just lateral to their junction, and the jugular veins. The right lymphatic duct is a very short vessel ranging from about 0.13 to 0.6 inches in length. It collects lymph from the upper right quadrant of the body. This deep duct is present in only 5 to 10% of the population. In most cases, the three collecting trunks from the upper right quadrant, which is the jugular, subclavian, and bronchomediastinal trunks, connect individually to the subclavian vein at the lymphatic terminus. The thoracic duct is centrally located in the thoracic and abdominal pelvic cavities, parallel and just to the left of the abdominal aorta. It is the deep duct responsible for collecting lymph from the other three quadrants of the body, the upper left, and lower right quadrants. A small bulge at the base of the thoracic duct, the cisterna chylae, is situated just below the diaphragm at the level of the second lumbar vertebra. It functions mainly as a passive collecting valve for lymph and for lower extremities via the lumbar trunks and some of the abdominal viscera. Time now for our second What Do You Think segment. Why is it important that the collectors and larger lymph vessels have valves while the initial vessels do not? Why is it important that both deep ducts return lymph to circulation at the subclavian veins rather than at the subclavian arteries? And why is there a structure like the cisterna chyli with the thoracic duct but not with the right lymphatic duct? Now let's discuss lymph nodes. Lymph nodes are small specialized lymphoid organs interspersed along the length of the collectors, making them a structural part of the lymph vessel network. Approximately 600 to 700 nodes are scattered both superficial and deep along the lymphatic pathway in clusters called lymph node beds. They function as filters, removing particulate matter, including dust, pollen, and bacteria, along with damaged cells and other cellular debris before returning the fluid to venous flow. Lymph nodes also contain numerous specialized immune cells, making them important sites for specific immune responses. Let's now consider the structure of lymph nodes. Lymph nodes may be round, elongated, or bean-shaped. They are 0.4 to 0.8 inches in size. Each node has several afferent, which means inward flowing, collectors with one-way valves that carry lymph into the nodes, and fewer efferent, which means outflowing collectors that carry lymph out of the node. The efferent collectors also have one-way valves to prevent backflow into the node. Having more afferent than efferent vessels creates a pressure differential inside the lymph nodes that facilitates the filtration process. A tough connective tissue covering called a capsule surrounds each lymph node. Projections called trabeculi extend into the capsule to the inside of the node, dividing it into compartments known as sinuses. Within the sinuses are small islands or nodules made up of clusters of macrophages and other specialized immune cells. Similar to the flow of a river that is impeded by boulders and numerous small islands, lymph flow through the node is slowed by the irregular network of sinuses and nodules. Now let's discuss the lymph node beds. As previously described, lymph nodes are interspersed along the length of each collector and clustered together in a few areas to form lymph node beds, also known in manual lymphatic therapies as catchments. The term catchment is used because each lymph node bed literally catches or collects fluid from a specific region of the body and slows the rate of flow. This decreased rate of lymph flow helps the nodes carry out their filtering and immune system processes. It is estimated that catchments create 100 times more resistance to flow than the entire vascular network of the lymphatic system put together. Catchments are located at hinge areas such as the anterior neck, axilla, inguinal, and popliteal regions. Each catchment has both superficial and deep nodes. Superficial nodes are situated in the subcutaneous layer of the skin, while deep nodes lie within the muscle, fascia, or body cavities. The primary catchments throughout the body are as follows: the axillary nodes, which receive lymph from the entire upper extremity and the thoracic quadrant of the trunk; the cervical lymph nodes, which receives lymph from the head and face; the inguinal catchment, which receives lymph from the full lower extremity, perineum, and lower abdominal regions, the popliteal catchment, which receives lymph from the plantar region of the foot and the posterior leg. It has its own set of deep femoral collectors to carry lymph directly into a small group of dedicated deep nodes in the inguinal catchment, which allows lymph to flow into the cisterna channeli at faster rate. The deep route from the popliteal to inguinal catchment acts as an express lane for lymph in the lower extremities. Now let's take a look at the manual therapy applications with respect to lymph nodes. Because catchments add resistance to lymph flow, all manual lymphatic techniques emphasize the importance of clearing these areas to increase lymph flow and reduce edema. Most forms of lymphatic therapy use stationary circles or pumping strokes over the catchments to improve lymph flow through these areas. Increasing lymph flow through the catchments is necessary for effective edema removal. Furthermore, in cases of lower extremity edema, it is important to clear both the popliteal and inguinal catchments. Doing so increases the rate of edema removal via the regular collectors in the leg and thigh, as well as the express lane connection to the cisternae chalae. And now it's time for our third What Do You Think segment. Why do lymph nodes have more afferent vessels than efferent vessels? Why is it helpful for manual therapists to refer to the clusters of lymph nodes as catchments rather than as lymph node beds? And why are most of the primary catchments located at hinge points of the body? Now, for this segment of our lecture, we will consider lymph formation and movement, specifically looking at pre-lymphatic channels and fluid uptake, general lymph flow, and lymphodomes and watersheds. Now let's take a look at the pre-lymphatic channels and fluid uptake. In most body tissue, fluid from the interstitial space drains directly into the initial vessels entwined with the cardiovascular capillaries. But there are a few exceptions to this rule, such as the epidermis of the skin, the brain, the deeper portions of the peripheral nervous system, the fibrocartilage, and the endomysium covering of skeletal muscle fibers. These tissues do not contain rich networks of blood capillaries, so the interstitial fluid in these areas must flow between and around the cells to reach the initial vessels of the lymphatic network. In these cases, interstitial fluid flow is facilitated by the presence of minute non-structural preferred pathways known as pre-lymphatic channels. Each person has a unique pattern of pre-lymphatic channels, but the purpose and function of this interstitial network is the same for all. Pre-lymphatic channels are formed by the repeated flow of interstitial fluid toward the initial vessels. Think how rivulets of water carve a channel into the earth after you repeatedly water a garden. The movement of interstitial fluid into the lymphatic capillaries is based on two factors: the fluid pressure differentials between the interstitium and the lymph vessel network, and the opening and closing of the epithelial flaps by the anchor filaments that project into the interstitium. In healthy tissue, the interstitial fluid pressure outside the initial vessels is slightly higher than the lymph fluid pressure inside the vessels. The higher IFP, as it is referred to, creates a slight stretch that pulls on the anchor filaments of the initial vessels to open the epithelial flaps, which allow interstitial fluid and large proteins to enter. The lower LFP inside the vessels provides the pressure differential needed to draw the interstitial fluid into the opened initial vessel. This process, called fluid uptake or edema uptake, creates a temporary shift in the pressure differentials between the inside and outside of the initial vessels. Now let's discuss the manual therapy applications for pre-lymphatic channels and fluid uptake. Understanding the fluid dynamics that affect movement of fluid into the initial vessels provides key physiologic rationale for the importance of using light pressure with all manual lymphatic techniques. Light pressure is necessary to avoid compressing and closing off the initial lymph vessels. It is also necessary in directing and supporting interstitial fluid flow through the pre-lymphatic channels. Let's now discuss the general lymph flow with respect to lymph formation and movement. Several variables influence lymph flow throughout the lymphatic system. Some are internal systemic forces, while others are external pumping mechanisms. One key internal force is the siphon effect created by the emptying of lymph back into circulation at the terminus. When lymph is emptied out of the lymphatic network into the subclavian veins, it creates a hydrostatic pressure differential that draws fluid from the lymphatic system into the subclavian veins. Like sucking on a straw, the emptying of lymph into venous flow creates the necessary negative pressure inside the lymphatic vessel network to facilitate pulling fluid into the interstitial vessels. Once the siphon effect has pulled lymph from the lymphatic capillaries and pre-collectors into the collecting vessels, the key internal mechanism influencing lymph flow is contraction of the ganglions. Lymph moves through the collectors via rhythmic contractions of the spiraled smooth muscle in the wall of each ganglion. Like all smooth muscle, the contractions are stimulated and regulated by the autonomic nervous system. In healthy tissue, a normal resting rate of 5 to 7 contractions per minute creates a slow but constant flow of lymph through the collectors. In addition to engaging in regular autonomic contraction, the smooth muscles inside these vessels can boost flow via a stretch reflex similar to that of skeletal muscle. In contrast, the simple recoil response of arteries when fluid enters the ganglions and stretches the walls of the collectors, it stimulates a reflexive contraction of the smooth muscles. This contraction pushes the lymph through the segment of the vessel into the next, so through the entire length of the collector. If volume of lymph entering the collecting vessel increases, the autonomic nervous system increases the rate of ganglion contraction to manage the elevated demand. So increased fluid uptake at the initial vessels creates higher volumes of lymph, which in turn stimulate faster contraction or collectors and improve lymph flow. The respiratory pump, created by deep breathing, exerts an important external influence on lymph flow through the lymphatic trunks and deep ducts. Deep inhalation causes a decrease in intrathoracic pressure that enhances the siphon effect, driving lymph movement throughout the system. Because the proximity of the cisterna chyli is the diaphragm, deep breathing applies direct external compression to the cisterna, adding an extra boost that propels lymph into and through the deep thoracic duct. Now let's consider the manual therapy applications for general lymph flow. When improved fluid uptake, arterial pulse, skeletal muscle contractions, and diaphragmatic breathing are combined, the rate of angion contraction and lymph flow can significantly increase. For these reasons, therapists can greatly enhance edema removal by using manual lymphatic techniques and encouraging clients to add simple forms of exercise and deep breathing to their daily activities. Light exercise, such as walking at a moderate pace, is one of the best ways to improve lymph flow. The combination of skeletal muscle contraction, full arterial expansion and recoil, and increased pulse and respiratory rates produced by such exercise leads to an estimated 20% to 30% improvement in lymph flow. By adding manual lymphatic techniques to a program of moderate exercise, the rate of lymph flow and edema removal can increase by as much as 50%. In cases of lower extremity edema, deep diaphragmatic breathing is of particular importance. Teaching clients to self-stimulate the cisterna chalae with a technique called exhale crunch helps extend improved edema removal well beyond the length of the session. Let's now consider lymph formation and movement with respect to lymphodomes and watersheds. The vessels of the lymphatic system are arranged in regional flow patterns called lymphodomes. Each lymphedome has its own group of capillaries and afferent collectors that form a predetermined pathway for lymph flow into a particular catchment and often to specific nodes. For example, lymphodomes in the medial and central tissue regions of the arm carry lymph into the axillary catchment, but lymphodomes on the lateral aspect of the arm bypass the axillary catchment and carry lymph flow posteriorly around the shoulder and directly into the lymphatic trunks and ducts. In several regions of the body, thin areas of tissue that contain a high concentration of anastomoses connect collector vessels from one lymphodome to those in an adjacent region. This zone between lymphodomes is called a watershed because the presence of an anastomose allows lymph to flow in either direction through the zone. Watersheds are functional boundaries rather than rigid physical structures. They allow for transferring lymph between different drainage zones. In the torso, they are two horizontal watershed lines, one at the level of the clavicles and scapular spine, and the second at the umbilicus. There is also a vertical watershed boundary at the mid-sagittal line. These watersheds form large drainage zones, each with multiple lymphodomes. The supraclavicular watershed regions have lymphodomes that carry lymph from the head and neck directly to the terminus. The thoracic watershed regions, located between the clavicular and umbilical lines, drain lymph from the regions to the axillary catchments. The abdominal watershed regions direct superficial lymph from the lower abdomen into the inguinal catchments, but lymph from the abdominal pelvic viscera follows a more direct path into the cisterna chalae or thoracic duct. Now let's consider the manual therapy applications for the lymphodomes and the watersheds. A helpful analogy for understanding watersheds is to visualize the peak of a roof on a house. On each side of the peak is a region that empties the rain into the gutter on that side of the roof. In this analogy, rain falling on the north side of the roof flows into gutters on the north side, and rain flowing on the south side flows into the south gutters. Rain falling directly on the peak of the roof can go in either direction, just as the high number of anastomomes at the watershed allows lymphs to flow in either directions. In this analogy, it is simply a matter of chance how much rain hits each side of the roof, and thus how much rain flows into the north or south gutters. But by knowing the location of the watersheds, manual therapists can purposefully direct edema to less congested lymphodomes and catchments to improve its removal. For example, with a shoulder injury or surgery, a portion of edema from the affected side can be taken across the back to the sagittal watershed. That portion of edema now flows into the unaffected and less congested side of the lymphodomes and catchments. If manual therapists are unaware of lymphodome flow patterns and watershed locations, they may inadvertently move edema away from the most efficient drainage zones. For example, all fluid in the anterior portion of the leg moves into the inguinal catchment. But it is important to note that there is a watershed between the lymphodomes of the thigh and those of the groin and genitals. If a manual therapist uses the wrong stroke direction through the anterior thigh, fluid may be pushed into the scrotum or genitals rather than into the inguinal catchment. Time now for our fourth What Do You Think segment. Describe the pre-lymphatic channels and how fluid flows through them to the initial vessels. Why is the flow through collectors subject to autonomic nervous system control rather than reliant solely on respiratory and skeletal muscle pumps? And why do you think most manual lymphatic techniques begin with deep breathing and strokes around the neck and terminus? Let's now discuss the types of edema. Edema is a sign of underlying dysfunction or disease. It can be from cardiovascular dysfunction, lymphatic dysfunction, or from soft tissue damage. Edema that is related to dysfunction or disease in the cardiovascular system, which is also referred to as dynamic edema, is the result of imbalance between the dynamic forces of capillary filtration and fluid uptake by the lymphatics. In these cases, the function of the lymphatic system is presumed normal, although it is temporarily overwhelmed by excess fluid in the interstitium. The cause of the imbalance between capillary filtration and lymphatic uptake must be identified and addressed to fully relieve this type of edema. Some common causes are hypertension, diabetic-related complications, circulatory strain due to pregnancy or obesity, congestive heart failure, renal insufficiency, and malnutrition. These conditions lead to increased capillary filtration due to an increase in capillary fluid pressure, decreased plasma, oncotic pressure, or impaired venous return. Physicians often treat edemas related to cardiovascular challenges by prescribing blood pressure and/or diuretic medications and recommending dietary changes for weight loss if obesity is an issue. These measures are generally successful in reducing edema by allowing the lymphatic system to catch up to the increased demand for fluid uptake and return. Now let's discuss the manual therapy applications with respect to cardiovascular dysfunction. In general, Manual lymphatic techniques are presumed safe and appropriate for use with edemas related to cardiovascular challenges. This is because the lymphatic system is healthy and functioning properly. But because it could be dangerous to enhance fluid flow in some situations, it is always important to identify the underlying etiology of any edema. For example, edema related to kidney disease should not be treated with lymph facilitation techniques because the enhanced fluid return could add stress to the already distressed renal functions. Likewise, with congestive heart failure, enhanced edema uptake might initially help to resolve edema in the ankles, but the increased fluid movement and overall return could eventually overtax the heart. This is due to the dynamic relationship between the lymphatic and cardiovascular systems. Even though manual lymphatic techniques are designed to enhance edema uptake and lymph flow, they affect fluid homeostasis throughout the entire body. So while manual lymphatic techniques may be used in cases of edema related to pregnancy, obesity, or impaired venous return, they are contraindicated in other cases, such as edema due to thrombosis or phlebitis. Therapists should refer to specialty textbooks on manual lymphatic drainage for a complete list of contraindications. Let's now consider the types of edema that are from lymphatic dysfunction. Edema caused by dysfunction or failure in the lymphatic system is called lymphedema. In such cases, the cardiovascular system may function well initially, but it is eventually compromised. There are two types of lymphedema, primary and secondary. In primary lymphedema, there is a congenital or genetic defect in lymphatic development resulting in an insufficient fluid return function. For example, there may be a low ratio of lymphatic vessels per cubic centimeter of tissue, or the valves within the collectors may be weak or too sparse. This usually becomes evident in early childhood and most often begins as swelling in the legs. This systemic insufficiency is a life-threatening condition that eventually develops into full-body lymphedema. Secondary lymphedema develops when the nodes or vessels or the lymphatic system are damaged or destroyed so that edema uptake and lymph flow are significantly compromised. Common causes of damage leading to secondary lymphedema include surgery, radiation, chemotherapy, infection, or repeated restrictions or injury to the catchments. For example, a high rate of secondary lymphedema is associated with mastectomies, axillary lymph node removal, and radiation treatments. In the 1980s and 1990s, the rate of post-mastectomy lymphedema was estimated at anywhere from 60% to 70%. However, more recent studies now show the average rate to be between 25 and 30%. This decrease in occurrence may be due to current treatment protocols that emphasize the removal of only a few axillary nodes and immediate use of therapeutic exercise and medications. Now let's consider the manual therapy applications with respect to lymphatic dysfunction. Treatment of lymphedema requires manual therapists to be thoroughly trained and certified in complex decongestive therapies and strict manual lymphatic drainage protocols. These advanced lymphatic drainage modalities combine the use of specialized compression garments and bandages with specific lymphatic strokes and strict adherence to precise patterns of lymph flow. Because physicians treating lymphedema often prescribe medications, therapists must also be well schooled in the benefits and side effects of these drugs. The use of other manual therapy techniques to address lymphedema is dangerous and could exacerbate the condition. Now let's discuss the types of edema that are caused from soft tissue damage. The localized and temporary swelling associated with soft tissue injury is known as traumatic edema. This edema is rich in protein due to the volume of plasma and intercellular proteins being spilled into the interstitium from the damaged tissue. Increased interstitial oncotic pressure causes more fluid to be drawn into the area in a process known as secondary edema formation. Since proteins causing the increased IOP are the sole responsibility of the lymphatic system, resolution of traumatic edema relies on stimulating the lymphatic system. This is certainly as important to proper healing of tissue as the cardiovascular system's delivery of repair materials. Traumatic edema cannot be fully resolved with the standard combination of long gliding strokes, such as effleurage, and kneading, which is patrissage, because the pressure from these strokes will most likely close the initial lymphatic vessels. But applying a combination of gliding and kneading strokes proximal to the edema may help to reduce swelling slightly by shifting interstitial fluid into areas of undamaged tissue where the number of lymph capillaries available for fluid reabsorption is higher. In addition, knowledge of the primary watersheds allows therapists to shift edema and interstitial fluid to entirely different catchments to improve the rate of edema removal. If traumatic edema is not fully resolved in a timely manner, it can become pitting edema. And here we see illustrated the classifications of edema, whether it is classified according to cardiovascular edema, lymphedema, or traumatic edema. Now it's time for our final What Do You Think segment. Why is it important for manual therapists to recognize the different types of edema? What health history information or objective measurements might a therapist use to determine if it is safe to use manual therapy techniques on a client who presents with edema? Now let's take a look at our pathology alert, pitting edema. When pressure from a finger causes a depression in an indentation that remains in the skin and soft tissue after pressure is removed, it is called pitting edema. This demonstrates that the buildup of extracellular fluid, which is edema, is not being removed effectively by the lymphatic system. There are many causes of pitting edema, including immobilization of an area after injury, deep vein thrombosis, and serious lymphatic kidney, liver, or heart dysfunction. In each of these cases, pitting edema is simply a sign of inefficient fluid return. The underlying cause of pitting edema must be determined before treatment of any kind is attempted. Okay, so we've reached the end of today's lecture, and for assignment number 11, we're going to be using the Thinking Beyond questions for this assignment. You're going to describe what is the functional advantage of the lymphatic system operating as a one-way return system rather than a connected full circuit like the cardiovascular system. How does this influence the intention and purpose of your work? Why is it important for a manual therapist to understand the different types of edema? And how could tight muscles and dense fascia affect the functioning of the lymphatic system? Now, if you have any difficulty at all with this assignment, you may send me a text message or an email. My office hours are on Thursdays from 4 to 6 p.m. And with that, I look forward to seeing you in the next lecture.